I'll now just do a quick introduction. If Anna would just forward the slide for me. Thank you very much. So today's talks are by Anna and Heather, very, very experienced people who know far more than I ever will about this topic. And with that, I will hand you over to Anna. Are you going first?
Yes, I'm going first.
Fantastic. Over to you.
Okay, hello. Thank you for coming to the decision modelling course today. So this is meant for the audience that either is involved in modelling or is interested to know how to interpret existing models. So you probably know who we are by now. We're a team of health economists and data analysts, data scientists at HEU. I'll briefly introduce myself and then I'll let Heather introduce herself. I'm a health economist. I was an academic until very recently. So I have a broad range of experience in various types of economic evaluations. I was at UCL for 8-9 years, and then prior to joining HEU, I was at an organisation, KITEC, based at King's College London, which looked at providing economic evidence in support of applications to NICE for digital technologies and medical technologies. And Heather, if you want to go next.
I'm Heather Humphreys, and I'm a health economist. I work with Anna, and I have backgrounds in public health analytics and in health economics.
Thank you. So this is session 4. This just kind of shows you where we are. There is one more session coming up on understanding equity in healthcare after this one. The aim of the session is to sort of explain what role modelling plays in economic evaluations. Heather will introduce you to sort of 2 main types of modelling, which are decision trees and Markov models. And then I will wrap up today by briefly touching upon hybrid models, simulations, and highlight some modelling challenges. So this is pretty much the plan for today. We'll have a 10-minute break at about 2 o'clock. And then we'll leave some time for questions at the end. What is sort of decision modelling? Generally, it can be defined as a systematic approach to making decisions in presence of uncertainty. It's been controversial for a very long time, but it has now grown more into prominence, especially with NICE guidelines that were published about 15 years ago or so. It's a set of tools. They are distinct from other types of economic analysis. So maybe think about what we've covered in the previous session, if you attended, as decision modelling really being complementary to other types of economic evaluation. And it is used to inform clinical decisions at both the population and individual levels. So to define it maybe a bit more precisely, we could think of decision modelling as mathematical relationships that define a series of possible consequences, and the likelihood of each of the possible consequences can be expressed in terms of probability. We in economic evaluations, think of each consequence having a cost and a particular outcome. And these are the consequences that would flow from a set of options that are being evaluated. So it thus becomes possible for us to calculate both the expected costs and expected outcomes for each option under evaluation. Decision modeling also allows for variability and uncertainty associated with decision-making process. So you can think of apparently identical patients responding differently to a given intervention. So sometimes, say, it could be characterized with a dichotomous event, such as response or no response to treatment. And the modeling can actually reflect that for an individual patient. But whether they will respond or not will be unknown in advance. And so the likelihood of a response will be expressed in terms of probability. I thought I'd give you an example of where modeling has been used. So this is the NHS Health Check, which is an example of an important locally led public health prevention service. It's offered to people without pre-existing disease, aged between 40 and 74, I believe, and it's free of charge every 5 years. The idea is to support individuals to make behavior changes and, where appropriate, access clinical help to help prevent the risks of various diseases. So an example of where modeling has been done is if we think of, say, investing into expanding this service. So for 10-year cohort prior to 40, say 30 to 39, what would the consequences and associated costs of that would be? What if we had some campaign to increase the uptake among those that are most deprived, or if the overall uptake changed, what would be the costs and consequences? Various types of models have been applied to answer those questions. So they can model the impact of external risk factors such as family history or some acquired diseases. They could sort of incorporate those that have maybe some existing conditions like obesity or high blood pressure. So modeling can take into account a wide variety of health outcomes. So we briefly touched on sort of trials when we in the previous session. So while trials provide sort of the sole source of evidence on both use of resources and associated health effects, and generally form basis of a good cost-effectiveness analysis, there are weaknesses, and Heather will touch upon that. I mean, I guess the most obvious one would be that there is a limited follow-up period, and they could be very expensive to conduct. In certain situations when it may not be ethical to run an RCT, and there's generally a very limited number of comparators. With modeling, we could compare lots more options than is usually feasible within a trial. We can link some intermediate clinical endpoints to the final outcomes. We could extend the horizon and think about survival beyond time period. Sometimes we use lifetime horizon of patients for particular models. And we can generalize results to other settings, thus informing how we allocate our healthcare resources most efficiently. So the good practice then can be seen as sort of both an RCT, a decision model, and mathematical disease models. So as I mentioned, RCT has advantages and disadvantages. So while being the gold standard and providing unbiased estimates, there are limitations. Decision modeling provides a way for us to synthesize lots of different information. We can use the RCT as a starting point for modeling, but we could also look at other studies and other sources. We're not going to talk today on mathematical disease modeling. That's primarily used for infectious diseases, and so sort of scope today. Modeling relies on the required features of any economic evaluation seeking to inform decision making. So the underlying studies that we can use for modeling must meet some key requirements. And this aligns with the NICE guidelines manual for the role of modeling. There are various checklists that are out there, but I'll present maybe the most commonly used one, which NICE also uses. This is from Drummond, and it's really a 10-question guide to which is applicable to any sort of cost effectiveness or cost utility that's done as part of primary research and that we wish to use for modeling. So I will break this down into sort of three main components and touch upon those in a bit more detail. So the first one is to define and present the decision problem. So if we're looking at cost effectiveness, then for a given technology, a program or an intervention can only be achieved in comparison with all alternative options that could be feasibly used in practice. This could relate to different sequences of treatments, or this could be sort of stop-go decision rules. Often an RCT will not compare all the alternatives. So we would need to bring together data from several clinical trials. And if you were with us in the previous session. Then we covered this in systematic literature review and touched upon meta-analysis. Defining the population and giving a clear description of the condition that's been evaluated. Decision analytical modeling can also think about different policies where so screening or prevention strategies are being considered. So you could think of, say, screening for type 2 diabetes. One policy would involve a one-time screening at, say, 45, and another will look at sort of 2 screenings at different ages. Another important point is the perspective, and Heather covered that in the last session. So thinking about the relevance of study for specific decision makers, be it sort of NHS perspective or an ICS perspective. And that tells us what costs and consequences have to be measured. And so turning to measurement and data, we have to think about what type of the study is being conducted and whether the choice of study is appropriate. And why is it being conducted? Is it something that's lacking in the current evidence base? So making sure that it's sort of not replicating something that already exists there. Economic evaluation should have useful data with high internal validity. So that can, of course, have an implication that it would have low external validity. So if we were to take the results from one setting, how transferable are they? How confident can we be that the same results would apply in another setting? Another point to consider is whether all costs and consequences have been identified, and that's sort of tied into the perspective. So we may look at just, say, an NHS perspective, but then we may think of even a broader perspective. For example, say you are conducting a randomized control trial investigating physiotherapy for back pain. So you could think that, you know, one way to approach it would be to look at the NHS perspective, but then there could be information on private treatment costs incurred by you, you know, getting to the treatment, costs of usual activities that you missed, so say, you know, sickness day from work. There could be some input by informal carers, so they may be looking after you with severe back pain. So that is more a societal perspective, a broader perspective. Again, thinking about how outcomes relate to research question and whether they are relevant and also fully justified. One thing to consider again is the time period or the time horizon. So for decision making, economic evaluation requires that studies adopt a time horizon that is sufficiently long to reflect all the key differences between various options, both in terms of costs and effects. And this is really where modeling comes into sort of its dominance, in that for many interventions, there'd be a limited time period, follow-up time period. But it is important, especially for those interventions that have mortality effect, or where life expectancy require estimation of survival curves. And then whether appropriate sources were used to estimate unit costs. And there are a number of publicly available sources that you could turn to. And then in certain circumstances, you would have to apply discounting as well. And finally is the analysis itself. So whether the methodology was appropriate. So for instance, sometimes costs and consequences are not normally distributed, and important to consider sometimes correlation between costs and consequences. And there are various statistical methods that could be used to address that. Subgroup analysis is also quite relevant. So there could be heterogeneity, and then various groups would respond differently to an intervention. So it is important in studies to address, and I guess the research question would determine what kind of subgroup analysis, whether you're looking at maybe, ethnicity or other sort of socio-demographic characteristic. And then in economic evaluations, we do the incremental analysis and assessing the uncertainty. And uncertainty is really key, and it sort of relates to whether a given policy problem would incorporate the fact that there is a probability that a decision may be not a correct one. So there is probabilistic decision models, and they can account for this uncertainty, so that when results are presented to the decision maker, this can translate into sort of a clearer picture and about the economic value. So topics that we will cover today are decision trees, Markov models, hybrid models, and simulations. And again, the last two, which just very briefly touch upon those. So before I hand over to Heather, I'll just maybe start by outlining the sort of main 3 steps in decision modeling. So one is sort of specifying the problem that identifies the population and analysis. So this will typically be relevant patients, but it can also include non-patients. For instance, if we're thinking about screening and prevention programs. And it requires specific details about the characteristics of individuals, but also setting, is it primary care, is it secondary care, is it both? So part of this definition really relates to who is making the relevant decision. So sometimes it is sort of explicitly known, for example, in submission for reimbursements, but sometimes it sort of has to come from the characteristics of the evaluation. The second step is defining the boundaries of the model. So, I mean, models are really a simplification of reality, and we need to make some choices about which of the possible consequences we can model. There are various examples, such as, let's say, in HIV disease transmission screening programs. So it has been shown that, say, including horizontal transmission into the model actually has a marked effect on screening cost effectiveness. And the next step is structuring a decision model. This can be based on sort of the nature of the intervention themselves. So you may want to outline the natural history of a particular condition and impact of various options on that process. So if you're thinking about, say, diagnostic strategy for a particular cancer, you may want to create a decision tree that will incorporate both the prevalence and also, if you're looking at a medical technology, some diagnostic accuracy of that technology. So I will stop presenting now, and I will pass on to Heather, who will highlight this in more detail.
That was great. Thanks, Anna.
Thank you, Anna. Clicked on it. Let's see if it will. This is the right one.
There we go.
Okay, so as Anna was just saying, basically models are a simplification of reality. And because of that, there are some significant things that we need to think about in how they deviate from reality in order to understand whether or not they're applicable to the situation that we're trying to understand. So we're going to cover a little bit about uncertainty. Uncertainty is not the same as heterogeneity. So if a population is heterogeneous, you might have, for example, higher costs for older patients because older patients have more complex care needs than a younger population. That's a known, we understand why those costs are different than another part of our population, why older patients cost more than younger patients. That's a heterogeneous population, but uncertainty is an unknown. We don't know whether it's true or false. There's some underlying uncertainty due to a variety of factors. And uncertainty is always present in an economic model. And failing to account for this or address it in an appropriate way can basically make everyone lose confidence in the results of the model. And it's really important to understand what types of uncertainty are more likely to be more present in models so that we can understand a model's generalizability in different contexts. So the main types of uncertainty that we're going to quickly run through are methodological, parameter, model structure, and then stochastic. these charts might be kind of helpful to keep somewhere for if you're actually doing some modeling as a reference point. But basically, methodological relates to your approach, the approach that you take to modeling. The parameter is there's something in the sampling of the different variables that are feeding into your model. The model structure is about the assumptions that we make. So when we're creating that simplified version of reality, we're going to make some assumptions. Like we might say we assume that all patients engage with the program. We might say that we assume that all patients must follow one of some identified paths that we create through the model. Stochastic uncertainty is random variation that might be present. And so these types of things are going to be in all models to some degree or another, and the relative degree that they're present can affect our results and our interpretation of those. These are some common distributions. So the distribution of values for any particular type of parameter might fall into one of these categories. And typically, for example, a utility parameter is going to follow a beta gamma distribution, and it's going to have like a continuous non-zero mean. We're not going to go into this a bunch today, but this is just kind of a good way to think about the fact that all distributions aren't the same, and you might need to consider different types of distributions when you're modeling. So second topic we're going to cover is sensitivity analysis. So sensitivity analysis can be done mostly in two ways. Either you do a deterministic sensitivity analysis or a probabilistic, and usually you'll do both. A deterministic sensitivity analysis, it's easy to assess the impact of an individual variable. In probabilistic, you're going to be looking at joint uncertainties across multiple variables. That's the big difference between the two. And it's difficult to interpret the opposite within each. So if you're using a deterministic sensitivity, it's difficult to interpret joint effects. If you're using probabilistics, then it's difficult to interpret the impact of individual variables. So there are three key types of deterministic sensitivity analysis. There's one-way, which is univariate, threshold analysis, and then multi-way, multivariate analysis. The advantages to this is that you choose one or more parameters and you keep the rest constant in a basic sensitivity analysis. And these allow you to look at which variables are potentially the most important for determining overall uncertainty. And this is really important in understanding what variables in the real world might have more of an impact on the situation that you're looking at. So for example, if the main variation is the patient's age, that might be kind of important to know if you're trying to apply the results of a study to a particular program where your population has a significantly different age distribution than that in the study. Some limitations are that this can be subjective or qualitative in essence in choosing which variables to perform a sensitivity analysis on. And there's no adjustment for the correlation between parameters. So there can be a limited uncertainty space that's covered here. We're not going to go through this whole table. This is mostly another thing that's kind of good to keep as a reference in your pocket, and it kind of goes through quickly what each of the different types of DSAs are and their relative advantages and disadvantages that you might want to consider when using them. An example of a DSA, we're also going to include that you can go and read through. This is a relatively very short paper that you can go read, and it has some specific application of a one-way sensitivity analysis to address the methodological uncertainty in the model, and some key areas that are generally disagreed about between economists are time horizon, discount, and perspective, which are kind of interesting in this particular paper. But from that, these are kind of some key graphs from this study. So if you look at these graphs here, one of the things that Anna mentioned was that it might not be feasible to have long time horizons when you're doing studies. So an RCT might not be able to feasibly run for 30 years to capture effects that happen after a period of time. So in this study, after the trial ended, which is this green dashed line here, you saw, you can see that while red and pink were trending together here, they then deviated after the trial end. And so extrapolating our results out can have really important consequences if you see significant variation after the end of a trial. So the results of trials like this are usually presented as one-way sensitivity analysis are usually presented in tornado plots, which are shown here, where the relative impact on the outcome of each individual parameter is ranked with the most influential one at the top. And this kind of is really useful in understanding which parameters might be the most important to consider in a policy evaluation. The middle line represents the ICER estimate using the base case of all of the base case values of each of the parameters. So this line here is the ICER for your base, and then the deviation above and below the line is the relative effect of changing the parameter within set values. A probabilistic sensitivity analysis, it's important that the input parameters are distributions. They're not point estimates. So the number is no longer, or the model is no longer run once. You run it maybe 10,000 times or 20,000 times. And each time that it runs, it will choose randomly different points from within those distributions. And this is where that table at the beginning of what type of distribution do all of my parameters have, this is where that comes in really handy, because you'll need to put relatively accurate distribution limits on your model so that it pulls within an appropriate distribution. The report is then going to take the mean across those number of runs and the corresponding uncertainty with that. And this is the recommended standard approach that's used these days due to the limitations from the one-way sensitivity analysis. So generally, you'll see this included in a model as well. So practically, if you're going to run one, the steps are going to be, you need to clarify which parameters to include. Not all variables within a PSA should be specified as distributions, only those that are subject to sampling variation. And then those that are known with certainty by the analyst remain point estimates. So like if you know that the cost is 800 pounds everywhere and that's not going to change, then you might not need to change that variable. If there's a distribution in the costs based on different parameters, then that wouldn't be true. So anything that you know with certainty might not need to be changed. And then choose an appropriate distribution for each parameter. So that table from the beginning where each of the different types, so like costs and utilities and stuff, have different types of distribution. Try to most carefully select which distribution is most likely relevant to your variables, and then sample from each distribution tens of thousands of times, and then summarize and present the results. So that same trial that they did on HIV and HIV negative individuals, they did a PSA as well, and the results from that are shown here. So this is what the results of a PSA will typically look like in a paper. You'll have a whole bunch of results, or a whole bunch of outcomes from using the different values that were sampled from the distributions, and you'll get these little clusters like this. And here, the green and the blue represent the two different countries. It's too small on my screen to actually read my key, but one of them is Zambia and one of them is South Africa. And then over here, you can see that in both countries, the cost per person per year has the greatest influence on the ICER, and then it's followed by the uncertainty in the different factors for misreporting of partnership formation rates, which will make a little bit more sense if you go and kind of look at the paper. But the key things here are that you can see the cost effectiveness thresholds here and how they vary and are different between the two different countries, even though they have relatively similar populations. And then you can try to understand why that might be. So decision analysis. Economic evaluations use models because we typically don't have all of the information about all of our population, and we need to make some predictions about costs and consequences based on partially available data. So economic evaluations, it's important to understand, are always they're strictly comparative. You have to have at least one alternative. You can't do an economic evaluation about one scenario without a comparator. The comparator might be no intervention. It might be not intervening, but not intervening in and of itself is a comparator. You're comparing against the do nothing option or the current practice, whatever that might be. And it's important to understand that economic evaluations are tools. They do not give you the answer. They give you information with which you can then make a decision based on an evaluation of the model in its entirety. So what were the assumptions? How much do those assumptions relate to your particular set of circumstances? And we went over that a lot more last week in critical appraisal, but it's really important to remember that a model is not going to give you the answer. It's going to give you information, and considering the uncertainty that's present in all models is really important in understanding what the model is actually telling you versus what you want it to tell you. So we've talked a little bit about the ways that you can represent values in previous sessions. So this is just kind of like a quick reminder that these are some of the variables that you might be including. This isn't, all encompassing, but generally you're going to be looking at costs and consequences in an economic model. And understanding which of those costs and which of the consequences to include is a key judgment call. That is a conversation between the analysts, the economists, the clinicians that are involved in defining that decision problem, as Anna was describing. So these values might come from real world data. They might be from trials that are ongoing in a particular ICS or a PCN, and they might be from the literature. So we might get these values from doing a systematic lit review or a targeted lit review to find out what others found. We might get the utility values from utility indices. For example, like we shouldn't be calculating on a local or a regional level utility indices for particular health states. We should be getting that from, accepted EQ5D, 5L published utility values, and then incorporating that into our models. So usually a model is going to pull from a variety of sources. And each of those are going to have their own uncertainties and all kinds of things that we need to incorporate and build into the methodology section of our report about how the model was developed and how to use and understand it and interpret the results. So decision analysis is where you take a quantitative approach to decision making. But remember, it's very key that it's always under uncertainty. Uncertainty is always present, and it has to be addressed. And decision analyses are a mathematical representation of possible events. So we follow a specified process, and we're generally looking at two alternatives. In decision analyses, we're always comparing two alternatives, and the probabilities and likelihood of each event and those associated outcomes and values are modeled. And the purpose is to then inform a policy decision where you're comparing clinical benefits and costs to evaluate something like cost effectiveness. But remember, it's not an answer, it's a model to be used to help develop an informed decision. So common steps in decision analysis are One, you're going to define the question. So what's your intervention? What's your comparator? Remember, you always have a comparator. There's never a situation in which you'd be doing an economic evaluation without something that you're comparing against. This is really key. It's a common misunderstanding, especially with like new tech. They want to say there is no comparator, we're the only one. Okay, but then you're comparing against what's currently done, the non-option. The perspective, the time horizon, the measures of costs, how long are you going to look at? Are we looking at a 1-year time horizon, 5 years, 30 years, a lifetime? Knowing and understanding that at the outset is really important. And then choosing an appropriate model. So we're going to go through in a bit of detail 2 types. They're kind of the simplest, the decision trees and Markov models. We're going to go through very simple examples because I don't think that everybody wants to do a ton of math today. I've chosen like the fewest number of branches possible to make it actually useful. And then Anna's at the end is going to go through a bit on epidemiological models and some individual simulation models, which are more useful for infectious diseases, so like COVID. The third step after you've chosen your appropriate model is to then identify evidence and populate that model, synthesizing evidence where possible. Analyze the model, so calculate out the costs, outcomes, and ICERs, and then validate the model and consider the impact of uncertainty. Sorry, I have a cold, in case that wasn't super obvious from my voice. So first off, decision trees. Quick show of hands, who has used a decision tree at work to do a project, to do some math? Raise, like, do the little raise hand thing if you've used a decision model before. Or sorry, a decision tree. Emma has? Okay. If you haven't used one, do you know what one is or how to calculate values using it? Or how to understand a decision tree if it's presented? Who's like done one in school or seen one before? See a couple of thumbs up. Sorry, Phil?
Just to say, I think people have understand it, they've just not used it yet.
Not used it yet. Okay, cool. So at this point, find either open up Excel in another little window where you can still see what we're doing here, or get a piece of paper and a pen, or a pencil, whichever is your preference. And you also might want a calculator or a phone, unless you like to do math with decimals in your head, because we're going to do that in a couple of minutes. So I'm warning you now so you have enough time to find something to write with, something to draw with, and something to do some math with. So Excel or a piece of paper and a pen, calculator or a phone. Okay, so while people are finding those, decision trees are generally drawn like this. You have a decision node, chance nodes, and outcome nodes. Decision trees always expand out going to the right, and they're always calculated starting at the end, at the outcome, and you do your calculations from the end towards the left. So you start from the right and you go to the left when you're doing your calculations. The pathways are mutually exclusive sequences of events, and the routes through the tree and the associated probabilities show the likelihood of particular events occurring at chance nodes and can be used to then calculate relative values associated with particular outcomes. Decision trees should only be used for things where you have simple decisions and short time horizons. It's not generally useful to create decision trees with hundreds of branches, or to use for long time periods. So for example, if you're doing something over the course of someone's life, a decision tree is very unlikely to be helpful because that's too complex of a problem to model with this method. Decision trees generally, like, I would use them in a situation where I'm looking at maybe the outcome of a surgery, because that's where you have a defined event, a couple of sets of outcomes, and then a relatively short period of time that you're kind of interested in afterwards. And then beyond a certain point, so maybe discharge plus 6 months, you're looking at, there's so many confounding factors that are going on that you're not really going to be modeling much past that. They're particularly suited to acute care problems, so treat or not. Once only diseases, so anything that you're going to have like the flu, where you can get it every year, you wouldn't want to use this. And then you're assuming that there's no transition dynamics, such as with infectious diseases. Decision trees should never be used to model something like COVID. COVID is much too complex for decision tree. And then short-term diagnostic and screening decisions. So basically short time frame and for simple problems. But that being said, they're surprisingly really useful, and we use them all the time in economic modeling, because a lot of decisions that clinicians in particular think are incredibly complex can actually relatively easily be used, can use a decision tree to model the economic components of that decision, which we'll get into with some examples in a bit. But first, we're going to run through an example. And we're going to calculate out the cost effectiveness of something together. So let's consider a situation in which you have patients with a hip replacement are at risk of DVT post-surgery. So it's not important that we know what that is, so I'm not going to go into it. Basically, you have a hip replacement, you either get a DVT or you don't after the surgery. And if you have a DVT, you can either have a bleed or not have a bleed. There are two treatments, heparin or the conventional treatment. And your research question is, which is more cost-effective treatment for hip replacement patients, heparin or conventional treatment? So basically, the decision that we're trying to understand is, after a patient has a hip replacement, should we give them heparin or the conventional treatment? And if we assume the time frame is 1 year, everybody with the piece of paper or the Excel document you've opened, think about how you would map the following using a decision tree. So draw one of these and put some simple labels on the branches. What's the logical way that you would present this type of problem? And I'll give you a couple minutes, maybe like a minute and a half. And if you have questions about where to start, either shout or pop it in the chat.
I think I should have started on a bigger piece of paper. Just realised my little A5 notepad might not be big enough for this.
You'd be surprised the number of notes I have where I've taped things together, Phil. That happens to me all the time. I always like write too big or underestimate the amount of room I'll need.
Start off with normal size writing and end up with it sort of only a microscope could read by the end.
Yeah, all of my diagrams. Okay, so if you are having a little bit of trouble of where to start, here's some key information pulled out. These are basically the 4 branchings that you're going to look at. And it might have started by looking at this. So the first step is that you're going to define your population. You've got hip replacement patients. And then from that, you've got your decision. So your decision is, do we give the hip replacement patients heparin or a conventional treatment? Next step is, do we give them, so once they have these treatments, the risk is that they're going to develop DVT or not. And the next step is, if they develop DVT, then having a bleed or not. Does anybody have any questions about how that you would get to this point? No? Okay, cool. So the next steps are we're going to populate the model using evidence. So remember that each probabilities are going to be written as numbers between 0 and 1, and you need to assign probabilities for all of the branches of chance nodes. And each of those probabilities of a branch from a node have to sum to 1. So the things that we're going to estimate are the total cost, clinical outcomes, and utilities. And then remember, when we do calculations, we always start on the right. So we always want to start on the left, but start on the right. So if I give you these assumptions, put these values where they would go on your decision tree. And if you swapped DVT and bleed on yours, swap them back. Otherwise, the rest of your calculations are going to be difficult for you to interpret. You could swap them if you wanted to, but we had to choose one option, and I went with this one. So to avoid multiple sets of math, let's run with this. Unless everybody chose the other way, and then I guess I'll adjust my math. Does anybody have any questions of how these values should be assigned, or is everybody kind of off and running, putting values places? Also, don't be shy, because the last time that we ran this course, nobody said anything until I asked what the value was, and then a whole bunch of people were lost. So shouting now is not bad.
Bethany's okay so far. I have to confess that I'm kind of drawing and trying to monitor the chat at the same time.
But Phil has an excuse to be behind.
Yeah, I may need a little longer. If I can get back to you before 5 o'clock, then that's fine.
Works for me. No time pressure. It's better to be accurate, Phil, than rapid. Okay, so decision trees are what we call rolled back to get the expected value for each strategy. So I'm gonna run through these a bit quickly because nobody said that they had questions. So this is the part where if you had questions, you can still ask, but now I'm gonna make fun of you slightly for not asking sooner. So you'll put your risks of the various states here. You'll assign your utility values here in green. Then you'll be able to get your costs of each type of branch. From that, you'll be able to calculate the qualities. So who can tell me what value they got for their quality for point A? And or for point C? Also, I was just kidding. I won't make fun of you for asking questions. Please do ask.
Yeah, I think people are still working it out. They're ahead of me because I was still drawing, so.
Cool. I have just noticed that it's 2 o'clock and I'm supposed to give you a break. So why don't we do this? Think about what these quality values are while you're grabbing a cup of tea or taking a 5-minute break, and we'll come back at 2:06 and I will continue telling you what the qualities and the cost effectiveness, relative cost effectiveness is of the heparin treatment.
Makes sense.
Maybe a 10-minute break, maybe till 2:10, right? So
10-minute break? Okay. 2:10 we'll come back.
2:10, yeah. Brilliant. You've got a few minutes to work it out. I think I'm just going to cheat and go back on the slides and do it again. Right. See you all in a minute.
See you all soon.
I hope everybody's feeling refreshed and had their calculators working furiously over the little break. I'm not going to lie, I didn't, but I'm just hosting, so I can get away with it.
You have a free pass, Phil.
I'll just pick your brains afterwards.
I think everybody should be about back.
Should we just get a quick hands up, make sure we've got a full house? Excellent. Brilliant. Yeah, fantastic. Sorry, I shall shut up now again.
And it looks like we've got the correct answer in the chat. Well done. So here's how that's calculated. Does anybody have any questions on that? Okay, cool. So from the QALYs, we can also calculate the relative costs of the two branches. And then we can solve for cost effectiveness. So cost effectiveness from previous sessions is the cost, the change in cost over the change in effect, which here is showing that the heparin arm has 2,500 per QALY gained, which would be below NICE's threshold of 30,000 pounds. Yeah? Any questions on this part? Or does that make sense? Looks good. Okay, great. So this is an example from a project that I did where I did a budget impact model on a particular app that was used to schedule appointments for GP practices, and we were doing the budget impact for a PCN. So here, the standard of care was that a patient walked into a practice, was given one of these types of appointments, and then either talked to the GP or the nurse on the phone or face-to-face. In the new pathway, electronic requests for appointments were submitted, and then a process was used to close queries off as admin, or they were passed on clinically, they were remotely handled, or addressed in different types of scenarios, basically. And so these are what our decision trees look like. In another example from our work, this was the standard of care, and then this was the new pathway as described by the clinician. So from lots of conversations and I guess stakeholder interactions, we developed, or we designed that this was the pathway as the clinicians saw the pathway. This is the clinician, or this is the pathway as the economists saw the pathway. So what's clinically important might not actually be important for your economic model. So for example, whether a patient remained on the waiting list, was reviewed by a clinician, or was removed from the waiting list were the three categories of interest at the end. So it didn't matter for the economic modeling why the patients ended up in one of these three boxes. So we were able to simplify the pathway a lot so that we could have a more usable economic model for actually determining a variety of things that we were interested in. And so this is how you could use decision trees to actually form the basis of an economic model. And then a lot of math on different sheets of an Excel tabs were used to assign values to each of these different states. So basically, decision trees are a structured way to represent clinical pathways. But importantly, we're able to put a synthesis of evidence around costs and effectiveness and clinical outcomes against each of the points on a decision tree, and it helps us weigh up and evaluate the relative risks and benefits of interventions. And it can allow for events occurring over time. However, it's got limitations. It doesn't efficiently Model events that occur repeatedly, so getting flu every year, or needing lots of checkups for asthma or diabetes. The trees become really bushy and unwieldy. And remember, the purpose of this is to provide a simpler representation of reality. It also implicitly assumes that events occur instantaneously. So there's no formal consideration of time. In the heparin example that we used, all of that was assumed to occur at once over that time-year period. It didn't account for a bleed happening in the first month after a surgery versus at month 12, right? And sometimes variables related to time are really important. For example, probability of all-cause mortality increases with age. There's no way to realistically demonstrate that in a decision tree. So another type of decision model that we might use is a Markov model. Show of hands, who knows what a Markov model is? At least a simple version of one. Emma does. And now raise your hand if you've used a Markov model for work in some way. So we're going to do a quick review of kind of simpler states of one to understand the basic concepts. So Markov models represent stochastic processes where you have distinct states. So each circle is representing one state, and there are a finite number of states. So everyone in your population has to exist in one of these circles. It's not possible to be outside of the circle. They're mutually exclusive and exhaustive, and they can be used to represent clinically and economically important events in disease processes, just like decision trees. They also, like decision trees, have values for each of the health states. So there's cost and consequences that we can assign to each state here. And then this can be used to estimate longer term costs and life years, qualities gained from different paths. So a key benefit of a Markov model is that it can handle recurrence, it can handle repeat events, which is important because people can be well for a long time and then relapse. It's also particularly suited to measuring things like chronic disease. So diabetes, asthma, cancer, and then diseases with specific stages, so like cancer or COPD. So a key thing is that there are a lot of different types of Markov models. So if you just search Markov model, you might find this whole list of a whole bunch of different specific applications that are variations in different modifications of Markov models. But a basic assumption is Markovian assumption, which says that the probability of moving out of a state is not dependent on a patient's history. So it doesn't take into account anything about where the patient was before. It doesn't care if the patient has been in that progression state for a year, 5 years, 10 rounds, doesn't matter. Everyone within the state is treated the same, and everyone within the state, whatever other states in the diagram they were in before, it doesn't take into account. Every restarting of the cycle, it doesn't have any memory of where you were before. So regardless of how long you've had COPD or cancer, whether you have traveled through other states on your way to that circle, isn't accounted for. So you can overcome this with some things like tunnel states, which we won't go into a ton, but basically they create fixed sequences. So like going through a tunnel, in order to get from one circle to another, you'll have to go through a series of events to get to another circle, which is kind of like a tunnel. You have to go through a certain step of pathways, but that adds a lot of complexity into the models, but it can be done. Okay, so Markov models are categorized about according to whether the transition state probabilities are constant over time or not. Because transition
Sorry to interrupt,
probabilities.
Heather. I think somebody's got their hand up.
Oh, sorry.
That's okay.
Didn't see that. Chung?
John, a question.
No, I think I accidentally pressed it when you asked who.
Ah.
Yeah.
Legacy.
Sorry
problem.
about that. Yeah.
No, you're fine. That's the risk of asking people to raise their hands for questions. Sorry. Yeah, so an example of this is transition probabilities where it's asymptomatic to dead. And then an example today, we're going to use a Markov chain, which assumes that we have homogeneous time. And then Markov process, where Markov processes oh my goodness, tongue twister. Markov process where transition probabilities are constant over time. And this has an analytical advantage where the probability of being at any particular state in time can be calculated. So up here, these are the key steps in developing and analyzing a Markov model. So the first step is you're going to define each of the points the same way that we did with the decision tree. So your transition states here, you're going to assign probabilities for movement between the states. So that's denoted by this notation here, where you have the probability for progression from asymptomatic to dead, the probability of progression from asymptomatic to progression, and then the probabilities that you move from progression of the disease to dead. And then you can also have probabilities for remaining in that state. So if you know 3 of the probabilities, then you can calculate all of the probabilities associated with the relative movements through the diagram. Absorbing states are states from which it's impossible to leave. So for example, we assume that death is final. You can't come back from death. So once you end up in dead, you stay in dead. And then Markov rewards are values assigned to each health state that represent the cost and consequences of spending a cycle in that state. So the next step is identifying your cycle length and then assigning the costs and relative utilities of being in that health state to each of the circles. So before we assigned the health states at the end of the decision tree, now we're going to assign the health states to each of the circles. So when you're in asymptomatic form of the disease, you'll have a particular utility associated with being in that state of health. When you're in a progressive state of the disease, you're assumed everyone within that circle is assumed to have the same utility associated with being in that state of health. Dead would obviously be 0. And then you'll look at it over a discrete period of time. And then you'll run the cycle a number of times until everyone ends up dead, because in the end, we're all dead. So if you ran the cycle enough times, everyone would eventually end up dead. A Markov model treats all the patients in a disease state the same, regardless of the time spent in the disease state. Remember, that's a key thing. It has no memory. So from one cycle to the next, we don't remember what happened before. And each of the time horizons here need to be equal increments of time. So each cycle length, you're going to have cohort simulations or patient level simulations. Cohort simulations, you'll have a hypothetical cohort of patients. They're homogeneous and they move through a system from well to death. In a patient level simulation, you'll sample one patient at a time or specify a number of patients in trials. And then a Markov cycle is that constant increment of time. So that's here. Each time that you run the cycle, the probability of moving through it, everybody is going to end up in one of your circles. And it's important to note that that happens at one time, and everything is assumed to happen at the start of the cycle. Sorry, I said that confusingly. In cycle 1, so in cycle 2 here, where you have a death, that death is assumed to happen on day 1. So this is obviously kind of a problem because statistically, not everybody who dies is going to die on the first day of the year. They might die all through the year. There are different ways that you can adjust for that, but unless you've adjusted for that using other methods, a Markov model is going to assume everything happens on day one. So all your costs will be incurred, and everybody who's dead, everybody who progresses, that will all occur on day one. So we're going to do another quick example where we look at what is the most cost effective between two treatments. So get your paper and pen or Excel or whatever you've used back out and draw a simple version of a Markov model where you have three disease states: well, diseased, or dead. The cycle is 1 year. The time horizon is going to be 2 years. So each cycle is 1 year, and we're going to look at it for a period of 2 years. The health outcome that we're interested in is life years. And there's two treatments. Treatment A is the standard of care, and it's £50 a year. Treatment B is you get a new medication comes out. We give it to everyone who is well, and it stops disease progression and prevents ill health. So basically what that means is that it's going to have the yearly probability of disease progression and dying. But remember, we only give it to those who are well. So quickly draw what you think the Markov model should look like and put the relative numbers and cost values where they go. It should take you about like 30 seconds to a minute. Does anybody have any questions, or does anybody say this is super easy, we're good with it, we can skip? Okay, we won't skip anything, Emma.
I think everybody's had about a minute. Oh.
Yeah. We're right in sync, Phil. That's exactly what I was thinking. So considering condition X, if we're looking at treatment A, these are the numbers that you should have drawn. So you should have 3 circles: well, developing condition X, or being dead. And I told you that the probability of disease progression is reduced by half with treatment B, but that's not true for treatment A. Your number of disease states should be 3, cycles a year, 2 years, etc. And then for treatment B, we said that the probability is reduced by half. So the probability of getting the condition is now only 10, and the probability of dying is reduced to 0.05. And this is what your transition matrix would look like. Any questions there on how I decided to slash these probabilities, for example? Okay, cool. So here's a quiz. For treatment A, if you have 1,000 people, how many individuals are well at the end of cycle 2? And same question at the end of cycle 2 for treatment B. Two numbers. Put the numbers that you think, put the answers in the chat when you have them.
An answer from Bethany.
Any different numbers than Bethany got? And also, what about for treatment B?
Excuse me, David and Sylvia's typing. Okay, so B 723 and agreement there. That's surely a good thing.
I've noticed that you both put question marks. Anybody want to elaborate on the question mark? You don't have to, but. I'm a fan of rounding up. So those numbers are right. Rounding up is fine. For anybody that was having a little bit of trouble in how you would get there, this is kind of how you would go through the math. So in cycle 0, you start with 1,000 well patients. You run the cycle once, and then you're left with 700 or 850. You run the cycle again, you're left with 490 or 722.5 or 723. Yeah. Okay. So then how do we get from that to cost effectiveness? Because remember, the reason that we're calculating this kind of stuff is because we wanted to know whether or not it's cost effective to recommend the new treatment that's become available, right? Because it's significantly more expensive than the current standard of care, right? So take a couple minutes and maybe like a minute and a half and fill in this table, these two tables. And then start to answer these questions here. And in case you didn't write it down before, here's the costs of the treatments.
I have a quick question for you, Heather. With my background, rounding up can mean the difference between getting the outcome you wanted or blowing up the lab. Is there a point where you wouldn't round up?
I think that's
and yes, I have come close to nearly blowing up the lab by rounding up when I was at university.
My brother and my brother's lab partner literally blew up their lab, and the Department of State in the US thought it was a terrorist incident and got the entire school locked down, and like the FBI swarmed campus, and it was a whole thing because his lab partner made some calculation error and actually blew up their lab. It was like a national incident. They thought it was a terrorist. It was all over the news country. Yeah, it was a major deal in the US. My brother was so mad because his model got blown up.
Oh no. No, I think they just expected us at King's to blow stuff up.
Yeah, well, no, it caused like millions of dollars in damage. They blew up a rocket on accident in the lab. Yeah, it was a thing. Yeah.
So would there be a point where rounding up wouldn't be allowed then, or does it have that flexibility in the modeling to not be affected massively?
So yeah, I think that this would be like a judgment call in any particular situation, because most numbers at some point you've rounded up. Like probabilities are very rarely like exactly 10%. The 0.9 and stuff that we've used is generally there's a rounding at some point. So I would suggest using kind of reasonable significant figures. For example, I tend to not count fractions of a penny. But I also don't tend to round until the end, especially because I'm usually modeling like in software that doesn't force me to, whereas right now we're all doing it on paper, so rounding is allowed. And also we won't blow anything up if we make a mistake.
Hopefully not.
Hopefully not.
But I think that's given people
quite
enough
shocked.
time, though, hasn't it? That little journey into chemistry to maybe finish their maths.
Yeah. Everybody good, or does anybody like desperately need more time? Okay. So here was a hint that I would have remembered to show if I wasn't remembering when my brother got, you know, the entire United States freaked out for a day. These are the costs that you would assign per cycle. Remember that it's 0 if you're diseased or dead. So here are the total costs and life years that you should have gotten. Does anybody have numbers that are different to these, or does anybody have any questions about how I got these? Raise your hand or do thumbs up if you got the same.
Well, that's good.
Cool, good. Okay, so step 2 is how cost effective is using treatment B compared to the standard of care? And then pop your answer in the chat. And you have it. You've done all the work. You've got to write in the report the number. Here's a hint. You should be calculating your ICERs.
Got a couple of answers, and they both match again, which is
Perfect.
positive.
Somebody's taking your rounding very seriously there, Phil.
Yeah, good. Don't want to see my computer explode.
And you guys are right. So it should be 5,866 per life year for B instead of A. So some common uses of Markov model. One of the most common ones you're going to see is for cancer. So if you relax some aspects of the Markov assumption by creating some additional states here called remission states, you can model the transition probabilities from remission to death, like so. And we'll include this paper. This is an image that I've slightly redrawn because it's like microscopic in the paper. For some reason, they used like size 2 font. So I've slightly redrawn it, but I promise it is the same information as the one in the paper where this is an example. But this is how you might use a Markov model to actually model something that you wanted to look at with cancer. And yeah. So there are some limitations to Markov models. There are strict rules around time. The clock is reset at each cycle, and probabilities are defined as constant. In reality, this is not true. The probability of getting the flu or catching COVID or a variety of things like developing more advanced stages of COPD might be related to comorbidities that you have, or your age, or your gender, or certain aspects of your lifestyle, how many people you come into contact with. Are you like me and do you need to spend an hour and a half on the tube to get into London? Or do you walk 5 minutes to work and therefore encounter significantly fewer people? These types of factors might in reality have a huge impact on how you would actually progress through different states. So these models can get incredibly complex if you're trying to model infectious diseases, which is why Anna's going to go over some models that might be significantly more appropriate. So quick quiz, which model type, just put in the chat like 1 DT or 1 MM for the following numbers. Which model do you think would likely, just based on the information you're given, throw in some quick guesses. What do you think would be the best for the following scenarios? And then thinking about why is a useful exercise too, which we will go through if anybody has any conflicting entries.
Feel free to turn your mics on, folks, if you want to discuss it, or by all means use the chat below. Entirely up to you. See typing, but nothing's appearing in the chat at the moment.
You don't have to answer all 5. You could answer in pieces.
Oh, Alex has had a go at them all.
Okay.
And David. Bit of disagreement there on the answers.
Interesting.
So another different answer. Emma's agreeing with David.
So does anybody, it looks like number 1 and number 2 have some variation, which is interesting. Does anybody want to say why they put one or the other for number 1? David.
Just because it's a very short time scale, simple decision. That's why I chose decision tree for that one.
Anybody that put Markov model want to say why they chose Markov model?
I think is that different? Chris's answer is slightly different again.
So we're going to come back to this in 1 minute, and I'll go through what I put as my answers. But first, I want to make a point using this quiz. So represent the following as a decision tree, and then draw it as a Markov model from the point where the patients are well until death. You have 30 seconds. And I've given a hint by, I've put in bold what I think, for simplicity, the 3 options or health states should be. I'll give you like 30 more seconds, and then I'm going to show you my answer. Okay, so this is what I put as my answer. And the point here is that I want to make is that we've said a few times in this course in the different sessions that all models are wrong, but some are useful. And the point here is that it's generally not the case that one is wrong and one is right. There's no, this is the correct answer and this is the wrong answer. It's, is the model useful for what we're trying to do with it? Does it adequately capture the relevant characteristics of the disease, the intervention, the costs, the outcomes, and how are we going to represent the relative structural uncertainty that we're going to introduce with our model selection? So by choosing to represent it either as a decision tree or as a Markov model, we are introducing structural uncertainty into our model. We are saying we're going to choose this model with all of the assumptions that come with it. So for example, in Markov model, we ignore where we've been before. We have no consideration of time. In a decision tree, we're assuming certain things about the time horizon. We're making certain assumptions about probabilities of being in different states, and using in the same scenario can be effectively modeled in different ways. So now going back to the quiz, what I put for my answers, I said that the first one was a decision tree, just because that seemed like a good method, but you could also model this with a Markov model. It would depend on your interpretation of the word triage. How many different types of triage? If you're triaging them, are you considering things like a waiting list where you might have to repeatedly triage? So for example, for surgery, every certain number of weeks, we have to revalidate whether or not those patients are in the correct triage position. If they get worse or better, what's the time frame we're looking at for triage? Is triage a quick decision in A&E, or is it something like a surgery waiting list which might span months? You might have different interpretations based on your experience or your understanding of the question that would change which one you chose. For number 2, I chose a Markov model because I was thinking of the relative stages of COPD and that you might progress from certain stages to another. COPD is also a chronic condition that occurs over a long period of time. So I might want to think about things like seasonality, like maybe you have more effects during the winter when it's cold than you do during the summer. I might want to model different types of I might want to use tunnel states to create certain aspects around COPD that I want to investigate. For number 3, I surveyed this on the team actually, and we split the health economics team. Half the team argued for decision trees, half the team said Markov models, and it depended on what people were considering as their end point. If the end is there's a high risk of complication, is it ignoring future progression of the disease? So is the key research question that we're interested in the progression of cancer, in which case we want to think about which one has a greater impact on probability of regression? Well, then we might want to consider a Markov model or a decision tree based on the time span that we're looking at, which wasn't given in the question, right? Number 4, I put a Markov model because there are various different types of stroke, and there are different like time aspects that you might have around, for example, I thought particularly that the idea of having the major or minor disability and then different movements between, like different aspects of this might be expanded out, that might be kind of interesting. But this, again, equally valid to have it as a decision tree. And then for the last one, I put a Markov model because, again, a substance misuse program is something that's going to be occurring over a long period of time. And with substance misuse, you are likely to have relapses. You might have different types of events that would have an impact on different probabilities of having a relapse, et cetera, that you might want to better model with a Markov model. So with the 10 minutes left, I'm going to pass to Anna, who's going to talk about some other methods that you might want to use for other particular situations where neither of these would be a good option. So, Anna.
Thank you very much, Heather. I will try to be fairly quick. I only have 4 slides, so please bear with me. So I wanted to touch a little bit upon hybrid models. A number of them have been proposed, and it's important to note that actually a lot of them retain some features of Markov models, but there are some ways in which they differ. So differential equation, so that is sort of a mathematical way to model, for instance, infection or the impact of a vaccination program, something that we call in economics externality. So one person having a vaccine provides benefit for others. These could be dynamic, this could be quite sophisticated, and for estimating things like infection prevalence, for example, those were shown to be more precise than other methods. So they prevent the overestimation that you sometimes see in other models. The second type is neural networks or artificial neural networks. They have been used previously mostly for diagnosis, but now they can inform decision-making at a micro level, so say between patients and healthcare providers. So there are some sort of very sophisticated deep learning models that model very high dimensional data. So for instance, if you're working with electronic health records, that is something that's a method that could be applicable, but again, with all models there are some caveats. So there could be some hidden relationships between clinical variables, for example, those occurring at short term and those are events that occur at a more longer term that may not be picked up. And there's also a question of sort of data completeness with electronic health records. So that can reduce the model performance if it's not handled appropriately. Another approach is dynamic Bayesian Markov models. So those are suitable when you have a very high number of states and where there may be dynamic changes. So things can be sort of updated based on occurrence dynamically. And another class is partition survival models. So that's mostly used in cancer modeling. So unlike the Markov model, here the number of people in any state at sort of successive points is not dictated by transition probabilities as such. So here we're estimating the proportion of cohort in each state based upon some survival equations. So you could, in cancer, incorporate sort of overall survival or progression-free survival, and there are sophisticated functions that you could build into the survival estimates. The one that I'd like to spend a couple more minutes on is discrete event simulation. So these have become quite, well, I wouldn't say popular, but they have been used a lot more in the last decade. And this approach can simulate dynamic behaviors of complex systems. And I guess the great advantage over the Markov model is that they can look at an individual level instead of a cohort level. So if there is some individual heterogeneity, as we see, say, in response to treatment, for example, this is a useful approach. And the idea behind it is that individuals, patients pass through a queue, and at sort of each interval, they wait in that queue. And that is kind of realistic when you think about healthcare and constrained resources. They also require sort of less computational intensity to work with, so that is quite attractive. It's kind of straightforward to answer the what if questions. So if you're looking to predict impact of various policy alternatives, it may be an approach that you may consider. So very briefly, you can incorporate various attributes into the structure. And how, depending on these different attributes, such as age, sex, health status, and demographics, but also disease history and duration of disease. So that will have an impact on how this affects the responses to various events. And events could be occurrence or recurrence of disease, but also admissions. So the models can be sort of updated as they're running. So if you have more admissions, or if the disease keeps recurring, this could be incorporated into the structure. But again, caveats. It's really the validity issue here, but also lack of necessary data. So you usually have to dig a lot through the literature or talk to clinical experts to populate the model. Last slide, I promise. The main applications. So they've been used for kind of optimizing operational and administrative decisions. So this could be, inpatient, outpatient clinics, A&E appointments, scheduling patients, capacity planning, staff schedules, etc. In disease progression, where you have various interventions and you want to look at, okay, what impact would this intervention have at an ICS level, or what about an NHS perspective, or what if we look at, as I said earlier today, NHS and a societal perspective. used in screening. And recently, this new area in health economics also gaining prominence, behavioral economics, so in behavior modeling. So this is to model trajectories of individual behavioral change over time in response to different interventions, to get to sort of the most influential mechanism for behavior solicitation, say stop smoking, or screening policies for breast cancer, etc. And I think I'll stop here. I'm not sure we have questions, I apologize. The last session next week, I believe next Thursday, is understanding equity in healthcare. And thank you very much. And here is a feedback form. We'd be grateful if you could complete it. So thank you very much.
Thanks, Anna. Thanks, Heather. That was a really interesting session. I hope everybody enjoyed it and got a lot from it. I put the feedback link for the form in the chat as well. If people would be kind enough to fill that out, it really helps us inform how we deliver the training. Sorry, Chris, did you want to say something? But I sworn I heard a voice then. I hope I did, otherwise
Apologies.
Oh, okay. And hopefully we will see you all next week. Thank you again for joining us. I'll stop the recording now.
Thank you very much.